Hi guys, welcome back to my channel. Today let's discuss about the staging of prostate cancer and how it is graded into ISUP grading system and the various risk groups and how they're helpful in managing the prostate cancer. So let's begin with the TNM staging of prostate cancer. So starting with the T stage, the T is divided into T1, T2, T3 and T4. T1 is inapparent or clinically not palpable. It is further divided into 1A, 1B, and 1C. These are incidentally detected tumors on resection of prostate. For example, a patient has undergone TURP and you find these tumor cells in the specimen. So T1 is not apparent clinically or not palpable clinically. T1A is less than or equal to 5% of tumor tissue in the resected specimen. If in the resected specimen it is more than 5%, then it is T1B. 1C is when the tumor is detected on needle biopsy. But not palpable. You have done a guided biopsy and it turned out to be prostate cancer, then it is stage 1C. Next, coming to T2, T2 are palpable tumors, but without extra prostatic extension. T2 is further classified into 2A, 2B, and 2C. 2A and 2B are unilateral, C is opposite side is also involved, both lobes are involved. 2A is when less than or equal to half of the prostate on one side is involved. 2B is when more than half of one side is involved. 2C is when both lobes of the prostate are involved. T3 is extra prostatic extension, but not a fixed tumor. 3 is further classified into 3A and 3B. 3A is extra prostatic extension is present, but no invasion into the adjacent structures. 3B is when it involves the seminal vesicles. Here are the seminal vesicles. With this extra prostatic extension into the seminal vesicles, then it is 3B. Stage 4 is involvement of adjacent structures. Or if the tumor is fixed. Only when it is involving the adjacent structures it becomes fixed. So what are these adjacent structures? This is bladder, this is the neck of the bladder, this external sphincter comes over here. So it involves the rectum, bladder, external sphincter, or invasion into the pelvic side walls or the levator ani. This is the T staging. Coming to N, there's only two categories here, N0 and N1 when there are no regional nodes. N1 is when the regional nodes are positive. M is for the M1 is presence of metastasis. M1 is further classified into M1A, 1B, and 1C. 1A is involvement of non-regional nodes, that is extrapelvic lymph nodes. 1B is bone metastasis. 1C is more than one site of mets. That is, if anything other than bone is involved, then it is called as 1C. Moving on to the next part, that is ISUP grading system. To understand ISUP grading, we need to understand what Gleason score is. Gleason score is a pathological score calculated from either the biopsy or from the final specimen. Here we look at the pathology slides and we see the glandular formation. So there are three Gleason scores: 3, 4, and 5. 1 and 2 are not included in the malignancy. 3 is predominantly glandular formation, abnormal glands, and 4 is a little less glandular structure. 5 is very minimal glandular structures. These are poorly differentiated. Cribriform also comes under 4. Presence of cribriform architecture itself means Gleason 4. We don't have to remember this part, but what we need to understand here is there's no Gleason 1 and 2. In malignancy, there's only Gleason 3, 4, and 5. So based on this scoring on the biopsy, for example, in a case of suspected prostate cancer, we have taken biopsies, transperineal biopsies, and at least 12 cores are important, so we have taken 12 cores, and we have observed this, sent this to the pathological analysis. And we found that among these 12 cores, we found that majority, that is 80% of the tumor tissue was of Gleason grade 3. And the next predominant 15% has Gleason grade 4. So then this becomes 3 plus 4, a score of 7. This 7 is used for ISUP grading system. So it is graded as the first most common pattern and the second most common pattern. They're added and the final score will decide our ISUP grading. So let us see what this ISUP grading is. ISUP grade group 1, group 2, 3, 4, and 5. Group 1 is a Gleason score of 3 plus 3, that is 6. 2 is when there is 3 plus 4, a score of 7. 3 is when the predominant pattern is 4 followed by the next most predominant part as 3, which is also again 7. Here what we need to understand is it is the most common type that comes first and the second most common type regardless of the grade. Next, coming to group 4, it can be either 4 plus 4, 3 plus 5, or 5 plus 3, which is score of 8. Coming to grade group 5, the score is 9 to 10. With the Gleason score of, it can be either 4 plus 5, 5 plus 5, or 5 plus 4. So these are the Gleason grade groups. These are useful in stratifying these tumors for management. Coming to the next part, prostate cancer risk groups. So the risk groups are stratified into low risk, intermediate risk, high risk, and very high risk. These risk groups are stratified based on three important things, that is the C staging, clinical staging, the grade, and the PSA, CGP. That's how I'm using as a mnemonic. So C, clinical stage T1 to T2A. Grade 1. This grading is again what we have just seen, ISUP grade 1, which means a Gleason score of 6. PSA less than 10. Coming to intermediate, next T2B to T2C, grade 2 or 3, that means a Gleason score of 7, with a PSA of 10 to 20. This intermediate group is further divided into intermediate favorable and unfavorable. Intermediate favorable is intermediate risk factors, that is, any of these three, any one of them is present, but in unfavorable group, two or three are present. And along with this, it is the group, along with these risk factors, the group is group 1, or here it is group 1 or 2, and in unfavorable intermediate risk, it is grade group 3. Or if the tumor tissue is present in less than 50% of core biopsies. If the tumor tissue is present in more than 50% of the the core biopsies, then it is considered as unfavorable intermediate risk group. Next, coming to the high risk group, it is T3 to T4 with a grade group of 4 or 5, that is a Gleason score of 8 or 9 to 10, with a PSA more than 20 nanograms per ml. Very high risk is again when it is T3 or T4 with grade group or 4 or 5 with PSA of more than 40 nanograms per ml. Coming to the management of these risk groups, low risk is you can give the option of active surveillance in these patients because they are progress very slowly, so you can keep them on observation. And coming to intermediate favorable risk group, these patients can be considered for watchful waiting, that is active surveillance, or you can give them an option for radical prostatectomy or RT. No further imaging is needed for these two groups, that is low and favorable intermediate risk groups. Imaging is needed from the unfavorable group. We need to do a PSMA PET and see if there's any evidence of distant metastasis because the management changes accordingly, or a whole body MRI is performed. You can consider these patients for SBRT or radical prostatectomy with androgen ablation therapy, androgen deprivation therapy for 4 to 6 months. Coming to the very high risk group and high risk group, these patients are considered for EBRT with or without brachytherapy. And here the androgen deprivation therapy is given for 18 to 36 months. In Stampede trial, they've given RT with 3 years of androgen deprivation therapy with abiraterone androgen receptor blockade for 2 years. Some other important definitions are what is biochemical recurrence. There's a clear definition given in ESMO guidelines. Biochemical recurrence following RT or biochemical recurrence following radical prostatectomy. Following RT, it is called as Phoenix criteria with a PSA nadir plus 2 nanograms per ml. Post radical prostatectomy, if there is rising PSA level confirmed by second test after a non-detectable value, if it is more than zero point 0.1 nanograms per ml. So that is in a nutshell about the management of prostate cancer and various staging and risk groups.